Welcome everyone to a second lecture on maternal health in India by Diane Coffey. I am JP. I and Pavitra will be co-moderating this session. Uh, I would begin with a small introduction of BE, and then I will begin with a small introduction of BE, and then Pavitra would introduce Professor Diane, and then we can head over to hearing the lecture by Professor Diane. BE was started in 2020. The group's objective is to provide a platform for students of economics belonging to marginalized communities in India to collaborate and support each other. Caste is well known to economists, academicians, not just in India but worldwide. Many books, papers, and articles have been written on caste and its impact on marginalized groups. Although it appears that caste is well documented, well studied, and well understood, all these books, papers, and articles uh, about caste and identity somehow only talk about it as a residual of the past, with no bearing over the present. Also, most of the scholarship is by people belonging to upper caste identity. The existing trend in academia is that the discussion on identities revolves around inclusion, but it rarely entertains the demand and need for representation of groups. Caste-based discrimination hasn't been ignored. This group aims to challenge that, along with an attempt to increase our representation in research. The group's objective is also to put forward our perspective that have been absent until now from the field. We hope to create a space in economics that is inclusive of historically oppressed communities in India. One of our most ambitious dreams is to have more Dalit and tribal women economists. We have organized sessions that will help students from marginalized backgrounds in the job market as well as research. We have had Python classes, statistics and stata classes, English speaking support session, and admission abroad series, etc. The aim is to equip students with tools that would help them academically and to provide guidance to students in the first and second generation. We at BE believe in making economics a field of study accessible for all and raising concerns that affect people's life directly or indirectly. In the same spirit, we have organized this lecture. I would now hand over to Pavitra, who is a BE member, and he will introduce Professor Diane, and then we'll begin. Over to you, Pavitra.
Yeah, thank you, JP. Today we are very delighted to have Professor Diane Coffey with us. Professor Diane is an assistant professor in the Department of Sociology at the University of Texas in Austin, and also a visiting researcher at the Indian Statistical Institute, Delhi. She is also the co-executive director of the Research Institute for Compassionate Economics, which is also known as RISE. So in terms of her research, she is a social demographer and extensively studies social influences on health in India. Her book with Dean Spears, Where India Goes, highlights that India's open defecation is not only a result of poverty, but also the consequences of caste system, untouchability, and religious purity. Her areas of research include gender, social stratification, maternal and child health, maternal entitlements, early and adult life health outcomes, mental health, and nutrition. She has also led surveys across India with other co-researchers at RISE. One of the surveys, the social attitudes research in India, which showed the persistence of prejudice towards Dalit, Muslim, and women in India, and argue for a need for a more robust and active policies. Her research also highlighted the worst mental health conditions of lower caste groups as well as Muslim minorities compared to other higher caste groups in India. So before I hand over the session to Professor Diane, I would request everyone to keep their mics on mute and share their comments in the chat box. We'll take them at the end of the session. So Diane, the floor is all yours, please.
Great. Thank you so much, JP and Pavitra, for that really fine introduction. I really appreciate knowing more about BE and its goals and achievements, and how kind of you to talk about some of the work that I've been involved in over the years. So I'm going to go ahead and share my screen. The presentation that I'm giving today is called Uncertainty. Can you guys see it? I'm not sure if I picked the right screen. You guys seeing one that has an orange PowerPoint? I think I'm on the wrong screen.
Yes, Professor. We can see that.
Oh, okay. Okay, great. So this paper in progress is called Uncertainty About Maternal Mortality in India, New Higher Estimates from the National Family Health Survey. And I'll just sort of say up front that unfortunately we don't have this, the maternal mortality estimates that we make from the National Family Health Survey for broken up by caste or religion. One reason that we haven't done that is because thankfully, maternal mortality is not that common an event that in even a large survey like the NFHS, you would get very wide confidence intervals on estimates by subgroup. So we're able to do regional estimates, which we'll see in a bit. We don't do estimates by caste or religion. I think eventually we should do it. I doubt it will end up in the published paper because I'm 85% sure that all of those confidence intervals are going to overlap. That said, I want to put out just sort of a shout out to some of my co-authors, Sangeeta Vyas, Ashish Gupta, and Payal Hati, who are researchers who have recently, they actually have a paper that's coming out in the Proceedings of the National Academy of Sciences, which is showing life expectancy differences using the annual health survey by caste and religion. And it won't be surprising to anybody in this group that even when you control for other factors, there's still a large life expectancy gap between Muslims and general caste Hindus, and between Dalits and general caste Hindus, and between Adivasis and general caste Hindus. And that I was just so delighted to get to sort of see that work develop over the years, and then for it to be published in such a high profile place. They also received an award from the Population Association of America for that work recently. So I definitely encourage everybody to check it out and to see if you're interested in sort of other work on mortality. I know that Ashish is working on caste disaggregated estimates of all adult mortality from the NFHS, and they're finding things that are pretty similar. The reason that that's going to be different for maternal mortality is because it's one group of the population, so just women, and then just 15 to 49, and then from a particular cause. So at that point, we're sort of getting fewer and fewer observations, such that it's going to introduce a lot of noise into the data to try to do it by subgroup. But nevertheless, I think should we have a large enough data set, I am really very confident that the maternal mortality estimates by caste and religion would reflect what we're seeing in the overall mortality estimates in terms of there being disparities. I hope that at some point, either the government of India or some of these large organizations would devote enough resources to get a sample size large enough to show that well. You know, until then, we'll want to be looking at other variables that don't have such large standard errors on them, like height. So you guys might be interested in a paper that I have in demography about caste gaps in child height, again, using the NFHS. And I think I saw a note from Aditi. Yeah, please do put your questions in the chat box. I definitely want to sort of respect the rules of the session. If I see something that I can answer that helps clarify, I think I'll go ahead and do it. Is that okay? Like, I won't save them all to the end if it's a clarification.
Yes. Please go ahead.
And I'm really delighted that Ashish is going to present the life expectancy paper. That's really great. Cool. So that's a little bit of sort of situating this work in a broader literature about mortality. And I just want to recognize my co-authors, Nathan Franz, Ashish, and Dean. It looks like none of them were joining. I think just it's an odd time in the US right now, 9 a.m. And so there's other meetings and things going on. But I know that they're excited about this work and excited about sending it out for publication. So just have some water. The story that I'm going to tell is a little bit gloomy. quite gloomy, actually. The sort of takeaway message from the research is going to be that we think that maternal mortality in India is a lot higher than the sample registration system suggests that it is, but I do want to put it in a global context of improving maternal and child health and improving maternal mortality around the world. So this is data from the World Bank showing that, throughout the 2000s, the rich countries have had really low maternal mortality. Maternal mortality, by the way, is death to a woman who is either pregnant or within a couple months of having had an abortion, a miscarriage, or a birth, either stillbirth or a live birth. So think of it as sort of things that are either pregnancy-related causes or things that could be exacerbated by being pregnant or having been pregnant. So that's what a maternal death is. And with the exception of the US, which has quite high maternal mortality for rich countries, we see that in rich countries, the maternal mortality rates are really very low. Around the world, maternal mortality is declining, and it's declining particularly quickly in sub-Saharan Africa, where rates are highest. So I am now going to add India to this graph. And according to this graph, which the World Bank data is taken from a UN WHO project that tries to compile the maternal mortality statistics that exist at a country level. And so the ones that they take for India are going to be from the sample registration system. And so these are sort of smooth data taken from the sample registration system and then adjusted in a not super complicated model that the WHO and the UN use to adjust and smooth data. And so their estimates are actually that India has lower maternal mortality than the global average. So we're going to be looking at the NFHS data to see whether it's consistent with the SRS data and with the estimates that the UN and WHO are using. And if we come up with something very different, then we might think differently about India's contribution to the global statistics on maternal mortality. Okay, so I don't have to point this out to you all, but when I give this presentation for international audiences, it's often useful to remind folks that India's population is a large share of the world's population. Although India's fertility is not particularly high, because it is such a large share of the population, it's home to a large share of births, approximately the same share as the population, so about 17% of births in between 2015 and 2020. So if we have a lot of births and a birth is sort of an exposure to a maternal death, we have a lot of opportunities for exposure to maternal death. Okay, so I just want to say that this graphic on this slide was taken from the Our World in Data website, and generally I recommend it. I think you can find a lot of interesting sort of little tidbits about trends in global health and trends in trying to understand how the world is changing from a social, educational, and economic perspective. So I definitely recommend checking it out. I take a little bit of issue with the question that they put at the top: how many women could we save from dying in pregnancy or childbirth? As somebody who works pretty closely with sort of women who are giving birth, you really have to be an OB or a nurse or a policymaker. You and I are probably not, I mean, we can be advocates, we can be researchers, but I think it's a bit of a strange thing to sort of suggest that you or I could sort of do something directly about this. Nevertheless, I think when these sorts of websites, they're trying to get us to think, they're trying to get us to engage with the numbers. So I get it, but I just don't want folks to think that I wrote that line. But the reason that I pulled up this little graphic was because I do want to highlight that around the world, many fewer women are dying in childbirth than used to be the case. So the red bar, I think that refers to, imagine that we had the estimated, this is somebody's model, rates of what was going on in 1800, we would have really a lot of maternal deaths around the world. We still have a really high number. The estimate is over 300,000, although if we add in the additional ones that we'll talk about from the NFHS4, it would be more. And we see just a really tiny fraction of that happening in the rich countries, which is represented in blue. And the reason that it's important to think about this, that each of these deaths, a maternal death is a lot worse than many of the other deaths that happen. What do I mean by that? Somebody might say like, okay, all lives are equal. The consequences of different people's death are different though. If we have an older person who's not really contributing to the family, certainly they'll be missed, but it's not the case that perhaps children aren't going to go to school because this person died. Or if we have a newborn who died, certainly their parents would miss them, but they don't have the sort of rich social connections to the community that an adult might have. And in particular, women of childbearing age are people who often have other children. So children are going to be left orphaned, and they're an enormous source of labor for their households. Like they are sort of the backbone of life all around the world, really, are sort of working age women. And so when a working age woman dies, a lot of people suffer consequences, which is not to say that her death in and of itself is not a tragedy, but it is also having consequences for a lot of other people, and particularly her children. So I just want to give a shout out to this paper from Demography. It's a little bit of an older paper now. It's from Sub-Saharan Africa. It uses data from the AIDS crisis in Sub-Saharan Africa in the 90s and early 2000s. So this is one of my mentors, Dr. Ann Case. She's an economist who worked with Chris Paxson and Joseph Oblidinger. And together they were looking at the consequences of orphanhood. And we see that in so many of the sub-Saharan African countries that they analyzed, children who are maternal orphans, and particularly children who have lost both of their parents, are just much less likely to be in school than children who are not orphaned. And so this is just sort of one way of proving with data all of the loss that occurs when a working age adult dies. So it's important to get this right. And I'll be talking at the end about how I think that the government of India and sort of the global statistics community are just not investing enough in understanding this problem. Although, we do have the goals. So there's the SDGs, the Sustainable Development Goals, and there's a sort of quantitative target that by 2030, global maternal mortality should be reduced to less than 70 per 100,000 live births. And that's going to be the way that we talk about maternal mortality ratios. So I'll get a little bit into sort of the technical details of maternal mortality at the end, but they've set a target on the maternal mortality ratio, which is maternal deaths per 100,000 live births. And so again, this is that WHO UN data. If we look at that, India is pretty low in terms of maternal deaths, especially compared to the sub-Saharan African countries, which are over here in blue. So I think that, if I'm remembering right, that's about 230. That could be the number from the NFHS. Don't quote me on that. We'll get the numbers on a future slide. Okay, so the SDG 3 sets the global target for the maternal mortality ratio to fewer than 70 deaths per 100,000 live births. And in terms of the total number of maternal deaths around the world, even these UN estimates say that only Nigeria has more maternal deaths than India. So how will we try to understand how many maternal deaths there are in India? Ideally, there would be something called a vital registration system. So those of you who have had a little bit of exposure to demography will already be familiar with this, but a vital registration system is sort of a government tracking all of the births and deaths that take place in the population. And unfortunately in India, that is incomplete. There's been a huge increase in birth reporting, so people who are registering the births of their children with the government, it's much less common actually, to register the birth of a child who died. Nevertheless, we have seen a pretty big increase in the vital registration for births, particularly births of surviving children. Vital registration of deaths is still quite low. Again, I'm sort of quoting from some work that Ashish is doing, finding that if a person is sort of a landowner, basically, deaths tend to get registered because that helps pass on the land. For people who don't have as many economic resources, especially women, deaths are a lot less likely to get registered. So really, there aren't demographers who think that it's yet going to be possible to understand maternal mortality in India from vital registration systems. We need survey data. However, when we turn to the survey data sources that are available, the SRS and the NFHS, we're going to see that they don't agree with one another. So what this paper does is compare the maternal mortality estimates in the sample registration system with the National Family Health Survey. So let me tell you guys a little bit about these two surveys. The sample registration system consists of a set of about 9,000 sample areas all around the country. And there are enumerators, actually sort of two sets of enumerators, a community enumerator and then someone who visits every 6 months. And their goal is to do complete vital registration, but within these 9,000 areas, so either like villages or census blocks. And the Office of the Census and the Registrar General administers this through the state government. So ultimately, the sort of people who work on this would be being paid by the state government of Uttar Pradesh or the state government of Tamil Nadu. And it's these deaths, also the denominators, the exposure that's collected by doing a complete census, that would be used to then sort of feed up to the central level, estimates being produced in the office in Delhi, and then that's the published data that the UN and the WHO put into their models to see the fancy graphics that you guys just saw. Interestingly, the NFHS also has a maternal mortality question. And so I sort of got into this, looking at this because I was writing about early life health in Uttar Pradesh. And when I looked at the numbers that the SRS had for maternal mortality in Uttar Pradesh, I thought that they were too low. It just really didn't cohere with my experiences on the ground of sort of the sheer number of maternal deaths that I've been exposed through my qualitative research. And so I wondered whether there was another data source other than the SRS that could help us understand the magnitude of maternal mortality, especially in that North Indian context, UP, Bihar. And so it turns out that even though the NFHS data for the NFHS 4 came out, when did they come out? Around about 2017, 2018. Nobody had actually analyzed the maternal mortality question in the household questionnaire. And when I talked to the DHS about it, they said that the reason was because they sort of developed the statistics to analyze maternal mortality when the module is a siblinghood method. So this is another way of collecting data about adult deaths, and the DHS has like a standardized way of going from that data to a maternal mortality estimate. The household death questionnaire, which we'll be using, is not used in many countries. And so they hadn't sort of developed the methodology to get a maternal mortality rate out of it. I want to give sort of a shout out to Tom Pullum, Dr. Tom Pullum, who is a demographer with the Demographic and Health Surveys who works on maternal mortality. And he was really helpful in helping me and Ashish and Nathan and Dean just sort of figure out like, okay, how would we go from the numbers in the NFHS to a maternal mortality rate? And, you know, as soon as we were on the same page, I thought, okay, this is it's good to go because this guy is the person who really knows. So one advantage that the NFHS has over the SRS is that it has about 25 28,500 primary sampling units. So you can think of the PSUs as equivalent to the sample areas. A difference is going to be that rather than doing a complete enumeration of all of the households in the sample areas, for the PSUs in the DHS, they're going to only interview 20 to 25 households in each PSU. That said, it's actually better from a measurement perspective to have a smaller number of households selected in a larger number of clusters. So if any of you guys have taken statistics before, and especially the statistics of sample surveys, you'll know that your standard errors, if you compute them correctly, are dependent on a number of things, but one of the main things is the number of clusters. And the more clusters you have, the smaller your standard errors are going to be. So the SRS number of clusters is so small that I expect that there would be wide confidence intervals on the mortality estimates. Unfortunately, and I don't know how much you all have the opportunity to talk to people who work with the SRS, but like a really important way that they could improve the quality of the estimates would be to publish clustered standard errors for their estimates. At the moment, they're not clustering their standard errors. And so whatever confidence intervals are published for the SRS are going to be too small compared to what they should be if they were clustered. But with the NFHS, we can cluster the standard errors, and we do. And that's going to lead to a higher quality estimate of maternal mortality. So, there's good reasons to really take the NFHS into account and to prefer it over the SRS. I'll talk about some reasons at the end why, we are a little bit skeptical about some of the data in the NFHS, but I think this issue of having more clusters is really important, and the fact that we can actually compute the correct standard errors for that sample design. Any questions so far? Okay. Okay.
Not in the chat box till now.
Nothing in the chat box, yeah. Sorry, I have one more sip of chai left and I'm going to drink it. Okay. So, as I said, sort of the reason for working on this was in part sort of my interest in the northern states with particularly high child and maternal mortality. And so we are going to separate the estimates by EAG states and non-EAG states. This is a government distinction empowered action group, an attempt to move away from the not very kind language of, what was it called? BIMARU states, right? It doesn't overlap exactly, but that's sort of not a good way to be talking about states. And so that was sort of, I think that was how the sort of EAG distinction was born. And it was the set of states was identified by the National Rural Health Mission in 2005, and they did get extra resources from the NHM. So, and I think, giving extra resources to these states in terms of maternal and child health was obviously a really wise move. They had 9% of the global worldwide, like all the births in the world occur in this region, and 15% of the neonatal deaths or deaths in the first month of life also occur in this region. And that's not just for India, it's a much higher fraction for India. This is globally. So it's a really important region to understand if you want to understand sort of both within India and global patterns of health. Okay, so what we do in this paper is to compute maternal mortality ratios and then compute the implied number of deaths from those ratios. And at the end, I'll show you a little bit of a decomposition that is just trying to help us understand why these two surveys have different results. The basic question that we're trying to get to is one survey identifying more deaths of women in the age range that maternal deaths apply to? So like, does one survey have more deaths of women 15 to 49, and that's why we see higher rates in the NFHS? Or is it that among the deaths of women 15 to 49, a higher fraction of them are maternal deaths? And I'll just sort of give away the punchline. It's much more the second thing about classifying deaths to adult women as maternal, as opposed to the SRS just not capturing as many deaths of women in that age range that the NFHS does. But there's a little bit of both. Okay, so here's like the main graph in the paper. Let me see if I can. Can you guys see the little red dot?
Yes, Professor. Yes.
Cool. Okay, so let's start with the all India numbers. So the SRS, again, we did not put the confidence intervals that they published because we knew that they were incorrect due to the clustering issue. So we just put the point estimates, the numbers that they published. So this is the SRS 2014 to 2016. All India, looks like it was about 125. If we go a little bit back in time, it looks like it was about 170 for the 2011 to 2013 period. And the UN and WHO, that's not an independent or a separate estimate, that's the SRS, sort of smoothed and modeled a little bit. And the confidence intervals are 80% confidence intervals, using a Bayesian model that the UN uses for all of the countries. And so it's no surprise then that UN estimate for 2014 is pretty close to the other two, although they did adjust it upward, I think, with also some suspicion that the SRS numbers were somewhat low. And then if we look at the reference period of 2012 to 2016, which is what the household death questionnaire in the NFHS covers, and we have 95% confidence intervals that are clustered, we see that it was about, so this was the 230 number, about 230 maternal deaths per 100,000 live births. So the confidence intervals for the UN and for the NFHS don't overlap, and the numbers for from the NFHS are much higher. And then if we look at like what geography in India is this coming from, it's not the South. The SRS and the NFHS agree that maternal mortality is quite low in South India. In the other states, so not EAG and Assam and not the South. So I think like Gujarat, I'd have to go back to that map that I showed before, but this is not a large number of states, which is part of why those confidence intervals are so large, that there's a small number of states here. So when we have only a little bit of data, the confidence intervals are wider. It's coming from that a little bit, but the major discrepancies are coming from those EAG states, UP, Bihar, Rajasthan, MP, who am I forgetting? Jharkhand. That's where the main discrepancy between the SRS and the NFHS are coming from. And we see that the SRS estimates are not within the confidence interval for the NFHS. So to me, this suggested that my sort of original reason for trying to find another maternal mortality estimate was sort of valid. So Aditi asks, is SRS estimate not for EAG states only? No, they break it up as well. So this is the SRS estimates for 2011 to 13 and 2014 to 16 for the EAG states. And then we coded those same states in the NFHS. Similarly, these are all the same states. And then this is all India. Does that make sense? Okay. Get rid of the pointer. Okay, so the sort of takeaway message here is that these differences in the maternal mortality ratio that we find imply a large number of additional maternal deaths that are not being captured by the SRS. And so the overall number, the difference implied by the SRS and the NFHS is about 21,000 maternal deaths annually. That's a lot. And about 4/5 of that, no, sorry, 3/5 of that is in the EAG states and Assam, and the rest being in the other states, but not in the South. And this difference, so when I presented this at PAA, the discussant there was, she was sort of blown away by the fact that just the difference between what's implied by the SRS and the NFHS is a greater number of maternal deaths than occur in the countries in DRC, Ethiopia, and Tanzania, which are the countries in the world that have the 3rd, 4th, and 5th highest number of maternal deaths. So Nigeria, which has an enormous number of maternal deaths, India, which now we don't really feel like we know how many maternal deaths there are, but if we go with the NFHS, it's much closer to Nigeria than if we didn't. And then these other 3 countries, large populated countries in sub-Saharan Africa with high maternal mortality rates. So it sort of matters which data source we use. And I just, for those of you who are sort of into demography and like to see different rates, this is the exact same graph as I showed you with the maternal mortality ratios. Now we do it with maternal mortality rates where the exposure or the denominator is no longer live births, it's person years lived by women. And so typically when you compute an adult mortality rate, that is your exposure. You can sort of think about it as whether you want to weight these births by the exposure of women or by the number of babies who are being had. And if you're doing this in global comparison, that's going to give you like a slightly different picture because some countries have higher fertility rates than others. But that's sort of a level of technical detail that we probably don't want to go into here. Let's just say that if we use another commonly investigated measure of maternal mortality, we see the same pattern comparing the SRS and the NFHS. Okay, so now we're going to return to that question of like, why is this happening? And so I'll have a variety of different types of answers to that. But one thing that we did sort of with the data to try to understand that was to look at whether it was the case that one survey was capturing more adult female deaths overall, or whether it tends to be about classification of adult female deaths as maternal. And so we do find that the NFHS captures a bit more all-cause mortality, but 80% of the difference of that 21,000 deaths can actually be explained by the classification of deaths into maternal or not. And this is done by age group. And so this is going to be the percentage of difference in the number of maternal deaths accounted for by differences in the all-cause age-specific female deaths. So now this is sort of the opposite of that statement that I just made. So it's just under 20% is accounted for by the difference in all-cause age-specific female deaths. And it's a little bit different by age groups. And in some age groups, we actually see that in one age group, 35 to 39 and 40 to 44, the SRS actually captures more maternal deaths, but overall, the NFHS captures more maternal deaths. But this is not the main driver of that difference in maternal mortality. It's mostly the fact that once an adult female death has been captured, the NFHS is more likely to assign it a maternal cause than the SRS is. And so, like, why is that? Sorry, I'm gonna talk more about it at the end. Yeah, I was trying to see what was on my phone. Go ahead.
Yeah, what you said, the last line where you said that NFHS assigns more. Sorry, I didn't understand. Could you repeat?
Sure.
Just a
The NFH, if they've found or identified a death to a woman between 15 and 49, which is the age range that applies to maternal mortality, the NFHS is more likely to classify it as a maternal death than the SRS is. So the SRS would say, like, yes, this woman is dead, but she wasn't pregnant or within 2 months of an abortion, a miscarriage, or birth. And I'll talk a little bit at the end about why I think that is, but it turns out I put it on the last slide. So I want to give a caveat. Like so far, I've really been saying like, look, I think we should sort of prefer the NFHS to the SRS. I still think we should, but as a responsible demographer, I have to share my doubts as well. And my biggest doubt is that there seems to be some problems with the age reporting in the household death questionnaire in the NFHS. So the unit level data for the NFHS, there are 615 women who, when you've got a woman and when the person who answered the household death questionnaire, so usually a senior member of the household, and this was about people who lived in the household within the last 5 years, they're asked, was she pregnant or within 2 months of a birth, a miscarriage, or an abortion? Surprisingly, only 450 of these women were actually in the age range of 15 to 49. And it's really not plausible that 65-year-old women were pregnant. And so we know that there's some issue with the data quality going on in the household death questionnaire. So the estimates that I showed you, we only use women who both were reported as 15 to 49 and were reported as, yes, it was a maternal death. But we don't really know how to think about those, 265, or sorry, less than 200 deaths, but still a large fraction of the overall number of deaths, those deaths that supposedly occurred outside the age range that is plausible for pregnancy. So we're sort of wondering what else was going on in the questionnaire. And when we try to sort of understand what is going on here, we don't find that there's like a particular state where the surveyors got this question entirely wrong and didn't get it. Like these misclassifications are spread across the country. And it's going to be pretty hard to go back and reconstruct. Like this is one question on an enormous questionnaire that has started happening, now 7 years ago. So more than that. So it's going to be pretty hard to understand what's going on. That said, the NFHS 5 just came out and just came out. I haven't had time to analyze it yet, but my hope is that that is not going to have the same misclassifications, and we're going to be able to just rerun this analysis and see, as a sanity check on this paper. But I don't want to say that the SRS data are the NFHS data are without any question marks. There is this kind of big question mark. So one question in the chat is, so isn't NFHS overestimating in the explanation you made for the basis of the age bracket? So I'll just go back to that. So here we're comparing we can do the decomposition with all of the ages and then sort of on average across age groups, about 20% of the difference in the number of maternal deaths as measured by the NFHS and the SRS is going to be because the NFHS finds more women at 15 to 49 who are dead, and 80% is going to be because among women who are dead that they find, they classify them as maternal. But if you then do that within each age group, things are a little different. And when this is above the 0 line, that means that the NFHS is finding more dead women in that age range. For 35 to 39 and 40 to 44, which are, by the way, age ranges where there's not a lot of deaths generally and not a lot of maternal deaths, the SRS is finding more deaths among women 15 to 49 in that age range. So that's what that graph is saying. One small clarification, is this NFHS 4 data? So in this graph, we're comparing NFHS 4 to SRS, both the 2011 to 2013 and, oh no, I think we're just comparing it to the 2014 to 2016. Okay, we did that one. Okay, So here's now sort of the takeaway messages why, despite the caveat that I described about the supposed maternal deaths to women outside of the appropriate age range, I still think that the NFHS estimates probably more accurate. One is that the NFHS is going to be administered by a standardized program at IIPS and the Demographic and Health Surveys, and it's sort of co-managed by this large team of researchers who really have a stake in high quality data. When we look at the SRS, that the sort of coordination, supervision, management of the survey is going to vary a lot by the state government that's implementing it. So some state governments that have sort of educated populations and high human capital government employees in general are probably going to do a much better job than states that generally have populations with lower education and where state capacity is generally lower. And, I think we see that pattern when we compare the discrepancies in the EAG states and the southern states. But I think one thing that, and, there's not going to be a lot we can do about that. And I don't want this, I don't want to take away from this talk to be that the SRS is somehow unimportant for India. It's extraordinarily important for India. We definitely need that data. It needs to continue to be collected. It should be improved, better funded, expanded. I think a lot more people need to work for the SRS organization rather than say like, let's just not use these data. I think that because this is sort of what there is, it should be, improved and cared for rather than discounted. One improvement that I think could be made to the maternal mortality collection in particular is that the way that they order the questions when they're trying to determine whether a death to a woman 15 to 49 is a maternal death is they're using a verbal autopsy form that's often filled about 6 months after the maternal or the death has been identified by sort of a local enumerator. So there's a local enumerator that just determines whether a death has occurred. And then once in 6 months, somebody's coming from the state to do a verbal autopsy and a verification. And it's only then that you start getting questions that will lead to a determination of cause of death. But maternal deaths are not as complicated to sort of classify as other types of deaths. A local enumerator may not be able to tell the difference between, say, malaria and some other sort of infection. You probably do need this complicated verbal autopsy process with a set of survey questions and then reviews by doctors to determine a cause of death like malaria. But maternal death, the definition is very uncomplicated, and most people know whether there was a pregnancy involved in this death. And so I think that, like the NFHS, the SRS should start collecting that information right at the time that the death is identified, possibly collect it then, and then also try to verify it later. And I would suggest moving away from the way that they're verifying it now, because at the moment, the question about whether a woman was pregnant or within a couple of months of a birth, miscarriage, or abortion is coming after a set of kind of questions that I think a lot of villagers would consider to be rude about their dead family member. So they ask whether the woman drank alcohol, for instance. They ask whether she smoked. And these are legitimate questions when you're trying to understand a cause of death. But if you're sitting there with I'm a dead woman, and you're sitting there with my husband and trying to understand what killed me, and start asking whether I was drinking and smoking, he's probably just going to start saying like, no, my wife was not sort of guilty of her own death, drinking and smoking and such. And then they ask, okay, and was she pregnant? And if you've sort of caught the person off guard, got them used to saying no, then I think it's just more likely that they won't be receptive to the questions that follow, and they may answer no incorrectly to the next question without sort of paying attention to it, really. So I don't think this is anybody's fault, but the way that this is definitely something that we saw in the SARI survey, the way you design the flow of questions in a survey really matters to the quality of responses that you get. And if you care a lot about measuring maternal mortality, you wouldn't do it after sensitive questions. You wouldn't sort of bury it deep in the survey. You would do it early. You would find really socially acceptable ways of talking about it, and you might have a cross-verification as well. The NFHS, on the other hand, has this single simple question that I think could be reproduced in the SRS to try to understand whether deaths that occurred to women 15 to 49 were maternal or not. Aditi, do we have examples of how these surveys ask questions? So I think I did. Do you think I answered that? Okay. Okay, so then sort of the main takeaway is that I really think we need further efforts to accurately estimate maternal mortality. The NFHS 5 is hopefully going to be part of that. I would love to see greater investments in the SRS, and sort of now a shout out to the international statistics community. If we want to reach SDG 3, we're going to need better measurement in the EHG states, and now to both the government of India and to sort of those who put pressure on the government of India through the UN and other international bodies. There's no doubt in my mind, I don't need better maternal mortality estimates than what we already have to know that we need large additional improvements in maternal health services, especially in the EHG states. Okay, that's what I had.
Thank you. Thank you. So please feel free to ask question in the chat box. We'll take that to Diane one by one.
Go ahead, Aditi.
Yeah, thank you, Diane. This is so informative and this is so important. Thank you so much. I have questions and comments. One is this point about how you ask questions and about the placement is a very important point, and I think demographers tend to give a lot of importance to how and where, in what ways they're asking the question. But I was also wondering that one, do we have any idea of this maternal mortality happening at, if most of this happens during the first birth, the first pregnancy of the women, or what is the number of babies after which this maternal mortality is generally mostly recorded? And the second one related to this was, I was also thinking that maybe a lot of people do not want to report mortality because they are also afraid that suppose it's the first pregnancy where the mortality took place, so they might also get framed in a way that they will be think of as accused that the women did not survive, or they're just trying to, because of some pressure and the way policy and laws have been working in India. Do you think that is also creating a fear because of which people are underreporting, because it's mostly men or women from in-laws side who will be responding to these questions, so they are just afraid of making this point? But I think this applies more when the maternal mortality is happening during the first birth, or yeah. Is the question clear?
It is. It's going to be hard to understand the relationship with parity, because if she dies on the first birth, then she's dead, right? Like she doesn't have exposure to others. We could still say like what fraction of women who die happen on the first, second, third, fourth birth. That is not information that I think is available. Like I don't think anybody's collecting it. I could look in the sisterhood method, but my guess is that because the person who gets asked is not necessarily really familiar with her obstetric history. So in the sub-Saharan African countries where it's a sisterhood method, it's like, have any of your sisters died and then were they pregnant? My guess is that the data quality on like exactly which parity was it would be pretty poor, particularly if you're not just wanting to count like live births, but also prior miscarriages or stillbirths or things like that. So I doubt that data is available. And in the NFHS, they don't have the parity they didn't ask the surviving family member who was reporting maternal deaths, the parity. It is an interesting question. You were saying about like whether there's fear of reporting this. So this is sort of an interesting point, which I think we should try to bring out in the paper. On this issue, I would think that the SRS would do better because they are continuously tracking the community. So if there was a daughter-in-law who died, and there's this local enumerator coming to the house every few months, then they're going to be asking, hey, that daughter-in-law who came, who's not here anymore, where is she? And so they couldn't really help but say, hey, she died. With the NFHS, if there's any shame in sort of delaying her care or in sort of not taking care of her during pregnancy, the household member who reports deaths to the NFHS is actually much more likely to get away with not reporting a death that they felt ashamed of than the SRS would be. And that's by virtue of the SRS being like a sort of longitudinal follow. I do think it could be an issue. I haven't seen anybody do like, I would think like a meta study of, okay, here's maternal mortality estimates from this, like a demographic and health site, DSS, demographic surveillance site type method versus a one-off household questionnaire. What are the differences? There would be other differences, but I do think that that would be like a really cool sort of review of the literature type of paper. You should think about doing it sometime. Should I answer Lakshita? Lakshita asks.
There's one more question by Abhishek as well on the chat.
Sure.
Can Pavitra read it? Pavitra, can you read it? Okay, I'll read it. NFHS takes into account data up to 5 years preceding the survey. How important is this fact while comparing NFHS with SRS?
Yes, it's important. So what we tried to do, am I still sharing my screen?
Yes, bro. Yes.
Yeah. Okay. So you'll see here that there is a bit of a different reference period. So the reference period for NFHS is going to be 2012 to 2016, and then the SRS published the sort of relevant years in 2 different maternal mortality bulletins. So 2011 to 2013 had some overlap with that period, and then 2014 to 2016. And so the way that we tried to go about sort of accounting for the fact that there were different reference periods was to just use all of the available data and then show that if we could get a reference period from the SRS to match the NFHS, it's going to be some sort of average of these 2 numbers, the 2011 to 2013 and 2014 to 2016. It'll be somewhere in here. And that's obviously outside, sorry, you should never say obviously. That is outside the confidence interval of the NFHS 2012 to 2016. So that's sort of how we know that these are different despite the fact that there are different reference periods.
Next question is by Lakshita. What do you think can be changed in the data collection methods of NFHS to tackle the issue of misrecorded age, cause of death?
Yeah, I think that's a great question. So one thing that I want to point out that we're now going to be pointing out in the paper, because I got a comment related to it when I gave a talk to a different audience, is that it's not a general problem with the NFHS that there is age misreporting. Most common parts of the survey that get used by demographers are the birth history and then the household roster. And both of those have ages. So for the birth history, that is going to be reported by the mother who had the babies, and she is pretty good at knowing when her babies were born. There's a bit of demography literature on sort of underreporting deaths and things like that, but by and large, the age data on children in the birth history in the NFHS and all of the DHS really is very good. And that comes from the person who's reporting it being really quite familiar with the situation. Similarly, the household roster is going to be filled by sort of a person who's knowledgeable about the household, and they're reporting on live people. So often, if you're reporting on somebody who's alive, either they're sort of sitting right there and kind of can correct you when you get their age a little bit wrong, or you know, somebody who's closer to them in the household. So like the husband might be more likely to know his wife's age, he might sort of correct it. So we do see some differences between the household roster ages and the ages of adults as reported by the adults themselves. And when we have data on both, we prefer the data that the adult, him or herself, reported. But by and large, there are not big differences between the household roster reported ages and the adult reported ages. So we also don't think that there are any large data quality issues with the household roster for live people. So we're looking at a very specialized set of questions that the DHS in India uses. My understanding from Ashish is because this is something that the IIPS professors were familiar with and had used in the past. I think it's really valuable. I think they should keep using it. That said, there haven't been a whole ton of studies about how you can improve the quality of asking a family member about dead people in the last 5 years. And you can imagine that it could really be harder to capture the ages correctly of people who had died. One thing is that they're not right there to correct you. Another might be that you're sort of trying to repress memories of them. It makes a lot of sense that you would get it more wrong with dead people. And off the top of my head, I really don't have a good sense of how you would improve that. Actually, I have one like slight idea that could be like a pathway for future research, and that like our team has sort of considered doing, but we haven't really had time. What we want to do is see whether if it's a certain person within the household who is reporting the death roster, do we have less of these errors, or is there less age heaping? So we could imagine that you could put some guidance to the NFHS surveyor to say like, look, if you have 3 people who are willing to report this death questionnaire to you, choose the person who's most educated, or choose the male person, or choose the female person. If there's anything that, because we do have who reported it, so we could look and see how observable characteristics, education, sex, role in the household corresponds with sort of known indicators of data quality, such as age heaping or this maternal misclassification. Does that help? I'm going to read Aparna's question.
Lakshita said, yes. So yes, Aparna's question is it possible to disaggregate NFHS data according to social groups for maternal deaths?
Yes, so this was something I talked about some in the beginning, and it's certainly possible to do it with all adult deaths or child deaths or other health variables, and should be done. The reason that we did not do it for this paper with maternal deaths was that we expected the confidence intervals to be extremely wide. So probably we should. If they all overlap, then we probably wouldn't even publish it in an appendix. If there were one that were a little bit different, then possibly we could put it in an appendix. But if you're somebody who's interested in doing that, like kind of email our co-author team and we can just send you our do file, and you can just change the 2 lines that, you know, put if social group equals such and such and see what you find.
Next question is by Akash. It's a bit lengthy question. He says the contemporary obsession among bureaucrats is to focus a lot more on investing in new databases in the name of case management systems and also transaction systems and so on. There's also a general sense to ignore surveys because they're sample based and go for administrative data. Do you have a take on this trend? among public administration? Is there a worry that surveys are getting delegitimized?
Yeah, I agree with this person. I think it was a really insightful comment. It's a real shame because we know that there's selection issues into who ends up in sort of an administrative database. And then there are data quality issues that come from the fact that it's ultimately bureaucrats who are reporting and bureaucrats whose performance is being assessed through the data that come through there. So, you know, if we're talking about, say, an ASHA who is supposed to visit, you know, all of the babies in the first 6 weeks of their life, she's not going to sort of admit that she didn't visit 5/6 of the babies that she was supposed to visit. She's just going to go through the administrative data and say, like, yes, I completed these visits. So both, like, we're only capturing people who are availing of those services and we're not seeing the people who aren't availing of the services. So an inclusion and selection issue, and sort of a data quality issue that comes from the incentives in that type of data collection. For research purposes, I don't think we should use this data for population research for trying to understand what is true of the population. I think we can, if we're going to be studying sort of public administration, access to public services, and incentives in public services, it could be fruitful to compare high quality survey data to the administrative databases to understand who's availing public services, and have some understanding of what might be happening in public services. But you would want to have sort of qualitative ground truthing to go along with your exploration of the administrative data set. Does that answer your question?
So the next question is asked by Sankalp. Any evidence of government scheme actually help reducing MMR in all EAG states?
That's a great question. Not really something that I have looked at myself. I really don't see good, it's not even really possible to write good papers about policy impact on MMR for two reasons. One being that, like, it's the data quality are poor and it's a rare event. So you're not going to be able to do like district variation and implementation of a policy and district MMR estimates simply because all of your district MMR estimates are going to have confidence intervals that overlap. I think that the best evidence for that sort of thing would come from sort of a deep understanding of the causes of maternal mortality. So, you know, I have a lot of confidence because I understand how women die in childbirth, that if there were emergency blood available at large hospitals, that would reduce MMR. And I know that that's not the case in a lot of places. I know that if we had really good treatments for patients with eclampsia, and a good sort of, okay, they're required to stay in the hospital for a certain amount of time after having a birth where there was preeclampsia, that's going to reduce MMR. And so you would want to go to like particular causes and then do like careful, detailed qualitative studies, but there's not the sort of level of quantitative data that you would need to explore that. The sorts of questions about policy impact using survey data or quantitative data.
Diane, I have a follow-up question on this. So we can't establish whether a policy has been able to reduce MMR, but do you think a correlational study can be done? Because over this last 10-15 years, there have been policies put in place to ensure that safe delivery or mother's health is being taken care during the period of pregnancy. So if we observe what has been the trend so far, I know you have said in the beginning of the lecture that MMR has come down a lot globally and in India as well, but I'm just trying to understand that if we can place policy in parallel to see what has been the trend, or we look at state-wise comparison where the policy has worked better compared to where it hasn't, and what has been the trend?
So unfortunately, I'm not familiar with good research on it. And I don't mean to say that it couldn't be done. And I think you wouldn't be writing sort of an economics type job market paper about here's my X variable that measures sort of the intensity of the policy, and my Y variable is MMR. It would be a much more careful understanding of are the sorts of interventions that we know reduce maternal mortality actually in place. And then you would try to do and if you wanted to sort of set up sort of a competing hypothesis that like, no, it isn't policy that's reducing MMR, it's actually just improvements in maternal health generally that the government really isn't responsible for. And I think the big one that you would be thinking about is nutrition, and particularly whether there had been any reductions in anemia, because anemia is related to the probability of death from PPH. You would sort of set those two up as competing hypotheses. So we know maternal mortality has gone down. Do we see evidence of interventions becoming more widely available, more women getting emergency obstetric care or postpartum care? And then at the same time, are we seeing improvements in maternal health? And like, if anybody wanted to work on that, like something that I'm actually like very excited about, I would be happy to be a mentor. I wish I had the time to do all of the research questions that are in my mind and in my heart, but I would be happy to talk with people about it. Like a little hint that I find very interesting is that I think he's not here, but I guess it was Pyle. So one of my Rice colleagues, Pyle, was here in Austin, like looking at the NFHS 5 data recently, and she was just sort of showing a graph of anemia rates among women of childbearing age in the NFHS 3, 4, and 5. And they basically haven't declined. And usually I'm the sort of person who's like pretty skeptical of government interventions as something that is sort of promoting change. I tend to think of like, you know, on the one hand, social struggle, on the other hand, economic progress as the sort of things that lead to improvements. And that failure of sort of population level anemia to come down suggests that if we are seeing improvements in maternal mortality, it may well be through greater availability of emergency obstetric care. So like, I actually think it's an open question and an interesting one.
Yeah, so next question we have from Abhishek. Is there any specific methodology that is prescribed by most researchers to compute the confidence interval for SRS estimates?
Sorry, can we point to where, this is Abhishek, any specific methodology prescribed by most researchers? No, I wish that more people cared about this. So the SRS, when they do give a confidence interval, it's a regular walled estimator. It's not corrected for clustering. And I actually haven't seen anybody sort of publicly request the SRS to publish the clusters. I mean, I think we should be really kind and polite about it. I'm sure that there are way too few people working in the office, but it would be a huge help to understanding what we actually do and don't know about mortality in India to have correct standard errors.
So next, yeah, Karthik asked two questions. Yeah, so one is, do the discrepancy and issues mentioned in relation to these two surveys exist in earlier surveys time periods as well? Like, is there a structural element to these issues, or is there a distinction in reliability across time? That was the first question.
And I would just say, I'm sorry that I don't know. I know that from one of the prior NFHS, you can get the maternal mortality estimates, and perhaps a researcher with more time on her hands would definitely have gone back to compare the NFHS 2, I think it was, with the SRS. And I'm sorry that I didn't. But if you do, please send me an email. I'm obviously very curious about it. What was the second one?
Yeah. So you mentioned that SRS data quality is variable and reliant on how states act. Could you give an example of what a state with a good quality data does versus one with less reliable data?
So Ashish is really the person to ask about this. I've seen him present a paper on Kerala and vital registration compared to the SRS, compared to the NFHS. And it's really cool. Like in Kerala, they are like all of these data sources really agree about mortality rates. So people are reporting the births and deaths to the particular government offices that collect vital registration system statistics. Then, we see the SRS enumerators collecting high quality data in their procedure. And then we see the NFHS with its procedure, and sort of they're all matching. So we know that there are places that are doing it well. We know that there are places where these three data sources just vary wildly. I'm thinking UP and Bihar. I could tell you sort of like particular things that are good survey practice, but I have not been involved in any research that say follows around an SRS researcher to see what it looks like when they do a good job or not. But I think it would be a great project. And I think if anybody's interested in it, I know that Ashish is just now back in India. And if you wanted to follow around SRS researchers in your state and tell them what you're seeing, I bet he would be really excited to talk with you about it and to sort of give you some clues about what are the sorts of things you should be looking for.
So there's another question by Taha. Has there been any evaluation on how overburdening of health services, like it happened in COVID lockdown, impacted MMR and broadly on maternal health?
It's possible. I'm not familiar with it myself. My guess is that it would have to be true. We saw people being turned away from health services sort of across the board, not just maternal health services, but other types of health services. And, for a woman who's bleeding, for a woman with eclampsia, for a woman with sepsis, that person is highly likely to die unless they get blood pressure medication or appropriate antibiotics. So I think it must be the case that COVID lockdowns increased maternal mortality. That said, I guess the only data source that would be out there that could possibly speak to it would be the NFHS 5. And where I'm going to sort of hesitate about saying that could be useful is that the NFHS 5 was, they'll say 2 phases, but when we think about sort of the data collection effort, we actually want to sort of think of it as 3 phases. So it was supposed to be a phase 1 and phase 2, different districts in different phases. There's some overlap across, some districts in some states were done in phase 1 and others were done in phase 2, but not it was not the case that it was a random sample of districts across the country for phase 1 and a random sample for phase 2, which would have permitted sort of better inferences. Anyway, so we've got phase 1 that was entirely pre-COVID, phase 2 where half of it was pre-lockdown and half of it was post-lockdown. And so I guess we could think of trying to do some sort of difference of maternal mortality in regions from NFHS 4. So we've got the pre-COVID and post-COVID. This is going to be a little tough because we've only got a few observations. And again, when we're looking at maternal mortality, if we're only looking at the fraction of the country that was surveyed in the second phase of phase 2, so the post-lockdown phase of phase 2, that's just going to be a really small fraction of the data, and the confidence intervals are going to be huge. We can do the imagination, but I don't think that the data are there to answer that question with data. Again, this is going to be go back to your qualitative research and try to understand were people being turned away, et cetera. And, I think maybe we don't need to go all the way to the outcome of MMR. There's, I think it was Vipul who's actually working with us some now, who has an article about I feel like maybe Aditi has worked on this. I'm sorry, Aditi, I'm not remembering. Reduction in access to health services during the lockdown, right? Like, we know it was there.
Yeah,
And
I
it
think
didn't
it's
kill people, right?
Yeah. No, it's not my work, but I think Vipul has been working on this.
Okay.
Yeah, and just to add to this, in the previous session on health, there was a doctor who joined us, and she just mentioned that this was our observation during the COVID, that maternal health has been declining because they didn't have access to healthcare. So yeah, but there is no, I haven't come across any study which has quantified it like you were saying.
I mean, I would maybe stay away from MMR, and just like you could use ANC visits, and that you would definitely have enough observations to look at. Right. Yeah, Lakshit, I agree with you.
Diane, I think we have covered all questions that come in. I just wanted one last question before we end this. So you have mentioned this in bits and pieces during the entire talk, but what are the primary causes behind higher MMR in India or worldwide, and what are the ways that government has been steps that government has been taken to take care of this issue?
Yeah, so I would say like the main push that government has made would be to increase the number of births that take place in health facilities. And, you know, there's actually like an interesting argument about whether that reduces neonatal mortality. And we could talk about that in another talk. I don't really have doubt that it decreases maternal mortality. So when it can decrease it more or less depending on the care that folks are getting when they get to the facilities. But the sort of major causes are going to be postpartum hemorrhage, which is something that occurs right away, eclampsia, which is about a woman's blood pressure being too high, and then sepsis, which is going to be about an infection that could occur either during labor or after labor. And so those are all three things that, you know, qualified medical providers who have blood, proper blood pressure management and medication, and the right antibiotics, and hopefully like even just hygienic delivery facilities are going to be able to either prevent or treat. And so like, yeah, I think that getting more deliveries to happen in those sorts of circumstances is really important. Another thing that like I could talk way too long about is the availability of emergency cesarean birth or emergency cesarean surgery. And this is like a really sad situation where we see an increasing number of people who don't need cesarean birth getting it because it's convenient and it results in more payment to doctors and nurses. And then we really don't see, we do see situations where people who need cesarean birth are turned away from public facilities that should be providing it to go to either sort of emergency deliveries, you know, on the way to another facility really bad, or to get cesarean birth in really precarious conditions with private providers who are unqualified. So sort of doing a better job at appropriately allocating cesarean birth would be another big way to improve maternal mortality.
So I just had one question. So since you have showed us the the differences between SRS estimates and NFHS estimate, but as we see that SRS is more regular, we tend to get it more on a yearly basis, and NFHS is a kind of 4 or 5 years gap. We see the data set after 4 or 5 years. So how these two survey data can impact different maternal entitlement policies or different policies taken up by state governments as a whole? Like there are central government policies, state government policies, and so on. So any thoughts, comments on that? Like,
I wish there were more of a link between the data and the policies, but we're in a situation with the maternity entitlements where so far are we from having maternal health policies that respond to sort of evidence. We're in a situation where back in 2014, the NFSA made it a legal requirement to give 6,000 rupee transfer for every birth. And somehow when that got translated into policy, it got turned into a PMMVY that only is giving it for the first birth. And then when we look at, this is a Jacha Bacha survey by a team of people who looked at, and I think Aditi was among them, who looked at whether people are actually getting this entitlement. Few people are getting it, and with delays. So we're just not in a situation where national and state governments are sort of responding to evidence on this issue. Not only that, they're not responding to legal requirements.
There's one last question by Hita. She's asking, in your experience, what have you been some of the specific social factors leading to MMR in India?
So one big thing that I sort of mentioned earlier is that women who are anemic are at a much higher risk of death when they bleed during childbirth, because they have less blood, they have less hemoglobin in their blood. So if they're losing more, they're more likely to die. And so there are all sorts of social factors that lead to anemia among women. Not eating iron-rich foods, including meat, which is important for building stores of hemoglobin. That's sort of an issue that we could sort of talk in detail about another time, but sort of caste, religious prejudices, purity pollution, all that has to do with why meat is a highly restricted food in India as compared to other places. And then if we look at just sources of nutritious food outside of meat, other fats, other vegetables can also help build iron stores. Pregnant women are often eating the least and eating last in their households, and that's certainly not doing them any favors in terms of preventing anemia.
There are no question in the chat box anymore. Yeah.
I think we should end the
thank
session.
you.
Yeah, I think we should end the session over here.
Yeah.
So
thank you, Diane, for this talk, and I would request the audience as well to look at our other work. Like one of the work is the SARI survey, which I've looked at and found it very interesting, that broadly captures how discrimination prejudice work in different states, which none of other surveys have done in a broad scale. So yeah, just concluding that, I'll hand over to JP and request to end the session.
thank you, Professor Diane, for taking time for a session today and offering a support time and again to BE members. I'm sure all of us learned something today, something new today. Before everyone leaves, I would like to announce two things and highlight them as well. We have a next session with Murad Banerjee on 12 June 2022 at 7 p.m. BE has also introduced its admission abroad mentorship program. The last date for registration for it is on 10th June. So if you are applying abroad next year or planning to apply abroad next year, make sure you register for mentorship. Yeah, that's it for my side. That's it for BE. And thank you all for staying this late and taking part in the lecture series. Thank you, Diane, again.
Thanks for having me.
Bye.